Not a problem. Good morning.
Good morning,
This
Commissioners.
is our 10 o'clock budget hearing for health access.
Should I go ahead and get started?
Yes,
All
absolutely.
righty. My name's Carla Hedquist. I'm the Executive Director of the Shawnee County Medical Society Health Access Program. And with me today is Dr. Scott Teeter. He is Chair of our Management Oversight Committee. We celebrated our 17th anniversary in March, and the county helped us get our start 17 years ago. Since that time, we have improved access to health care for over 15,000 unduplicated low-income uninsured residents of Shawnee County. We're modeled after a best practice in Buncombe County, North Carolina, and we continue to be an excellent example of community collaboration. We combine donated hospital care, physician care, dental care, optometry, and prescriptions in a coordinated and efficient method that is run by the Shawnee County Medical Society. We are one of only 4 counties in Kansas that have this model of donated care. There is Project Access in Wichita that serves Sedgwick County, and there's Wyjo Cares in Kansas City. So I tell our patients how lucky they are to live here and to have access to this kind of donated care. Our goals have remained the same: access to care for low-income uninsured, improving the health of low-income uninsured, therefore the health of our community, and making our safety net more efficient for both patients and physicians. We focus on preventive health and we work with many different arms of our local safety net system. Once enrolled in health access, all of our patients have to have a primary care home, a medical home that they can go to for all of their needs. 79% of our patients go to Grace Med, so that's almost 1,300 people. 17% have private physicians, such as Dr. Teeter, who see patients right out of their own offices, Cotton O'Neill, University of Kansas Health System, Washburn University. And then we're seeing an increasing number of patients go to Pine Ridge Family Health Services and Vallejo for primary care. Once enrolled in health access and they have a primary care home, then they can be referred to specialty care that's donated. And of course, then they get the prescription card that's very important. Our role is to recruit the physicians and monitor the referrals that they receive so we can spread the charity care efficiently amongst all of them. So the physicians only receive the number that they've agreed to donate to in a given year. Right now we have over 300 physicians who are donating. We also ensure patient eligibility every 6 months to make sure that there's no potential for payment. So if individuals have a medical card, of course, they're no longer eligible for health access. If they are workers' comp, anything like that where there's a potential for payment, then we would not enroll them in health access. We have 3 eligibility criteria. They need to live here in Shawnee County, not have any other kind of health coverage, and make less than 150% of federal poverty. And for a household of 1, that's $1,561 a month right now. So, you know, when you're thinking about $700 insurance premium coming out of that, then you can understand why folks don't have coverage on the open market. Right now, we have 1,638 individuals who are enrolled in health access and receiving donated care. We assist the working poor. They're the people that don't qualify for a medical card because they make too much. They don't qualify for Affordable Care Act because they don't make enough to qualify for the subsidy. So there are those folks right down the middle that are the working poor that would be covered if Kansas expanded Medicaid. 58% of our patients are female, so a lot of single moms who are making decisions about their own needs versus the needs of their kids. Only 16% of our patients own their own home. Our top employers are food service, labor, temp agencies, places that notoriously just don't offer health coverage. 35% of our patients have less than a high school education, and 79% of them are less than 100% of federal poverty guidelines. Having access to preventative care and prescriptions keeps people out of the more expensive emergency room. In our May patient surveys, 93% of them indicated that they had not been in the emergency room in the last 6 months. So we're proving that once people have access to primary care, specialty care, and prescriptions, they don't go to the emergency room. We're also continue to see an increasing number of what I call emergency referrals. They come from the hospitals and the clinics. They're being discharged without a primary care home, without any insurance to be able to get their prescriptions, and so we're enrolling them on the spot once we can prove that they're eligible so that they can get those things and not be readmitted. We've had over 350 of those kinds of referrals so far this year. Last year at the same time we were at 254. Examples of those referrals would be victims of domestic violence, sex trafficking, dental issues, diabetic complications. We saw quite a few homeless this last winter. One who had to have his leg amputated because of frostbite, heart attacks, strokes, cancer. The need's great. This spring, we received a 2-year grant from the Topeka Community Foundation to actually look at and work on helping our patients with the social determinants of their health, which is those root causes beyond access to care. Our partners are Stormont Vale, Harvesters, Vallejo, and the Washburn School of Nursing. It's called the LINK program, and that's our way of working on improving the county health rankings and making progress on the goals that are identified in our community health needs assessment and our community health improvement plan that's in the works right now. Today I'm requesting continued funding for prescriptions because the physicians believe that it's critical to the success of our program. It does no good for the hospitals and the physicians to donate care if people can't get their prescriptions and get well. It also influences our physicians to volunteer because they know that they're going to have that support that they need when the patients need their prescriptions. An example would be prescriptions needed for seizures or hypertension or even something as simple as an earache. When a physician diagnoses those things but they can't get their prescriptions, then what good does the diagnosis do? They require prescriptions to maintain their health. We work really hard to maximize our prescription funding. We only help with generics. We don't do anything over the counter like Nexium or that kind of thing, prescription Tylenol. We never do narcotics or pain medication. If the patients go to GraceMed, they have to use the GraceMed 340B first. That's the federal funding that helps with prescriptions. We encourage them to use the patient assistance programs and apply for prescriptions for free or reduced price from the manufacturer to reserve their health access funding for things it doesn't cover. The pharmacies have all agreed to maximum allowable cost, and they don't charge health access a dispensing fee. Our patients pay a $9 copay right now. If it's on the $4 list, of course, they just pay the $4, but they don't pay over $9. Commissioner Cook serves on the Health Access Management Oversight Committee, and they review at every meeting our prescription utilization and expenses to make sure that we're on track. We also have a subcommittee that looks at prescriptions that is made up of physicians and staff from the prescription network, and they get into the detail of making decisions about our formulary to make sure our money lasts and goes as far as possible. Things in the last year, changes that we've made would be things like something that was offered extended release. They said that's more expensive. The patient can take 3 pills a day, and we can reserve our budget, and it's equally effective. Something like Tamiflu that didn't have as proven of outcomes, so they didn't offer that on our formulary. Our number of patients utilizing prescription cards has increased. In 2014, it was 26%. In 2018, we had 33.94%. So we're seeing patients need their medications more. And also the number of claims has increased from last year. On the prescription utilization sheet that I handed out, you can see that we've had 22,227 physician claims as of the end of June. All of 28, we had 28,000 claims. So we're up quite a bit on number of claims. Last year, when I came to talk to you, we were quite concerned about our prescription budget, and I was predicting a $20,000 deficit. The fourth quarter brought wonderful changes. The prescription network does our maximum allowable cost negotiations with all the pharmacies, and we had just this perfect storm of the generics that health access patients use and their negotiations on behalf of all of the individuals that they represent lowered our costs significantly, almost half in the fourth quarter last year, and we are continuing to see the results of that. So we're very thankful for their partnership. And I'm thankful personally because the prescription subcommittee of physicians has told me there is no other cuts that we can make to our formulary without really hurting the integrity of our program. And so then it would be on me to find the additional funding. I want to thank you for your ongoing support for the last 17 years. In 2014, Health Access was receiving $122,500 from the County Commission to help with prescriptions. And in 2015 and 2016, we actually requested less. We requested $100,000 because we'd found some cost savings and didn't want to ask for more than we needed. Last year, we received $110,000 from the county, and we are requesting level funding for 2020. Of that $110,000, we'll use $7,500 of it, so not quite 7%, to help with program administration. The remaining $102,000 actually goes directly to generic prescriptions. The City of Topeka Subcommittee recommended funding of $49,000 for health access for prescriptions for 2020. We received a 98% on our grant application, but our funding is capped at $50,000. And of course, they have not voted on the social service funding yet. Our administrative funding comes from the Topeka Community Foundation and the United Way. We also do an annual fundraiser, music, just what the doctor ordered, and this one was our best year yet. We made over $20,000 to help us with program operations. So thanks to physicians like Dr. Teeter who show a different side of themselves to help the program out. We continue to work really closely with GraceMed. Like I said, 79% of our patients go there, and we still have a health access eligibility specialist who's located on site at GraceMed, and they donate that office to us. Towards our goal of a efficient safety net, we encourage people that we think might be eligible for affordable care, ACA, to apply for that if they're eligible. We continue to encourage all of our patients to visit the marketplace and see what they might be able to get that way. We work very closely with the navigator at GraceMed during open enrollment. What happens is we might have some who apply for Affordable Care Act and receive it, but then there's others at GraceMed who don't qualify and they get referred to Health Access. So we don't necessarily reduce our numbers at that point in time. The need for health access continues. We still have many low-income uninsured patients, especially coming out of the hospitals and clinics. We are finding patients need more clinical intervention, and they need help with patient navigation, which is why I'm really excited about the LINK grant and our ability to actually work with patients in a different way. So why should the invest in prescriptions for low-income uninsured? As you all know, health is a community-wide issue. You see the community health needs assessment, you see the improvement plan. Health impacts our ability to work. 87% of our patients say that health access helped them get a job or stay healthy to be able to work. It helps patients be able to take care of their property and their family. They can shop and pay sales tax and be productive, which is what makes a vibrant community. Sick people, on the other hand, spread illness, and that impacts all of our productivity. Prescriptions help keep people out of the expensive emergency room, which also impacts all of us in rising costs. And then without prescriptions, some patients that have behavioral health issues might exhibit behaviors that would require intervention by emergency personnel or first responders or ambulance calls. So that's another savings. So that old saying, an ounce of prevention is worth a pound of cure, is evident within our program. I believe our community's strength really lies in our ability to take care of those who are less fortunate. We receive federal funding, we don't receive state funding, we are not an entitlement program. We exist because the Shawnee County medical community comes together in this way to donate care for Shawnee County residents. We are local physicians, local hospitals, clinics, pharmacies, all coming together to keep our local community healthy. We have recorded over 177 million in charity care and assisted over 15,000 patients since the program began. We have 1,637 individuals enrolled right now, like I said earlier, and 5.8 million in donated care year to date. I always tell you that our patients aren't here to say thank you, but I am. And this year I brought with me patient survey comments, and I just want to read you a few of those that have come in just the first 6 months of this year. I promise not to read all of them. There's 6 pages.
Yeah,
But
okay.
some of the ones that spoke to my heart: thanks for all the help I've received from Health Access. Thank you for helping keep me healthy. I don't know what I'd do without this. Thank you. Your program has changed my life for the better. My mind is able to rest. I would not be healthy without this. Thank you very much for this opportunity. Thanks to the prescription card, we can obtain our medicine for an affordable price. This program is of great help with my prescription and doctor visits. Thank you for being there for me. I've been able to get my medication. Thank you for this program. I could not afford prescriptions if it weren't for this help. I appreciate the program. If not for it, I wouldn't have any health care. Health Access has helped me get my back surgery, and it's helped me to a better road getting back to the workforce. Thank you. I'm grateful for having these cards that helps me take care of my health and buy my medicines. Without it, I would not be able to afford my medication. I can't afford my meds without Health Access. Thank you very much to all of those that work for Health Access, the doctors, the nurses, for helping us to have a better life. Thank you, and God bless you. So I do thank you on their behalf for your support of prescriptions for the patients. We do think we're making a difference in our Shawnee County residents who are low income and uninsured. Dr. Teeter and I would stand for questions.
Commissioner Cook, do you have questions for Carla or Dr. Teeter?
Just comments. The Health Access does reflect the entire medical community. We have Grace Med, we have Shawnee County Health Department, KU, Ardent, the Stormont Vale, the CRC, the Community Resource, the Community Foundation,
United
the
Way.
Doctors, United Way, really just Optometry Association. So you really have a conglomerate of all the different medical providers in Shawnee County in one space, really focused in on meeting that gap of individuals that are between health insurance and governmental assistance when it comes to prescription medications. So we do have a lot of work that goes into, like for instance, looking at insulin for diabetics, making sure that we're able to get that insulin out, making sure that it's in the right quantities. The doctors are going through constantly looking at, are there other alternatives to the costs? And so there's a lot of given donated care.
Insulin's a good example. It's critical because if you don't have it, you're back in diabetic ketoacidosis and back in the hospital. And we pay high dollar for a short-term insulin until we can bridge them onto the pharmacy giveaway plan. So that's an example where it's critical. We do a little bit, but then we get them onto something that doesn't require ongoing funding because it's hooked up through the benevolent care pharmaceutical giveaway plan from the manufacturer on that one. So the insulin that's in the drug program is just what we call bridging insulin until, the waiting period to get on the giveaway.
So when we talk about a public-private partnership, this is, Carla made the comment, I think maybe 2 years ago, that the #1 deficiency in Health Access is that they've been around long enough and it works, that it's no longer the flashy new thing. And so it's hard to get attention.
Stole my thunder.
Man.
I was going to say, imagine we're pitching a pie-in-the-sky plan that for a small seed money can get 300 physicians enrolled, all the hospitals in the community, all these other people to work together, the pharmacy benefit thing to get a rock-solid bottom dollar drug plan together and provide care for this many people for the next decade, and then say, hey, you don't have to imagine whether it's a pie-in-the-sky plan. We've already done it,
We've done it
and we
for years.
continue to do it. So think of it as a brand-new thing that you're going to provide some chance seed money to, and that feels better, but.
Yeah. I was told when I was hired that, we aren't empire builders. We aren't trying to make health access bigger, as I'm the only full-time staff and we have 2 part-time people and a couple of wonderful volunteers. But really, our mission has stayed tried and true, and we have good results because of it. We haven't been distracted.
Commissioner Rippon, do you have anything to add?
Sure, I have some questions. The prescription drugs, you said the drugstore, they don't charge a dispensing fee or anything. Do we get do you get like a wholesale price on these drugs?
It's called maximum allowable cost, and it's negotiated by the prescription network on our behalf.
That seems
And
misleading
it's,
because it's a rock bottom.
yeah, it means
Okay.
it's
Word
the maximum
maximum.
allowable that they can charge.
Oh, okay, so they can't add anything to it for a dispensing fee or
Right,
anything
yeah,
else.
Okay.
yeah, because you or I, if we go to any different pharmacy, we're
Mm-hmm.
gonna pay a differing amount.
Right.
Where health access patients will pay the same amount, no matter which pharmacy they go to.
Would you say most of your patients are inside city limits or?
Ooh, I should have brought those statistics. I don't even wanna,
They're all within the county.
yeah, they're all
Within
within,
the-
yeah, Shawnee
Well,
County is they must
Just
be,
because of the
but,
population within the city limits, I would
Probably.
think it would
Yeah.
have to be
yeah.
a significant.
Right,
portion.
I can tell you our top zip code is 66605,
Yep.
out by Avondale East.
Yep.
And then followed by North Topeka, around the Mission. We have a lot of Mission folks who are enrolled, as well as people who live in North Topeka and East Topeka, and of course, Central Topeka.
It's where the working poor are.
Yeah. Yeah, we know
Yeah.
that.
And then I had a question on your proposed budget here under, I guess it's Topeka Community Foundation and other funds, funders for prescription. I notice it goes to 0. Is there,
Yes, and that's what I was talking about in terms of the cost savings that we found. When I put our budget together for 2019, it was last September. And we were still experiencing a $20,000 deficit at that point, predicted year end for our prescriptions. So I thought I was going to have to look for that 19,000 whatever in additional prescription funds. And I knew that the Community Foundation and other organizations had that. We have not had to do that this year because of the Prescription Network's negotiation on our behalf. And so I took it out of our 2020 budget because it's going to stay the same.
one other, are there federal or state grants available to help your?
We
The
were,
biggest federal one is Grace Med's, what's the name of that?
oh, the
numbers?
Community Health Center and
The pharmacy.
the 340B pharmacy.
340B pharmacy.
We were involved in a large gatekeeper grant with multiple organizations. I still worked at Vallejo at that time, so it was over 13 years ago, that Health Access was involved in, and Vallejo and multiple community organizations. And United Way actually hired a staff person to oversee that program. It was Larry Hinton. But that was the last time we were involved in something that big, and it was a federal grant.
That's it for me.
Okay. I've been hearing your story for 6 or 7 years now and appreciate the work you do for our community. And Dr. Teeter, thank you for being here this morning, and I don't have anything to add, so unless you do, Commissioner. Again, thank you. Thank you for being here. We're
Thank you.
adjourned until 11, when we'll hear from Clark.
Thank you.
Thank you for hearing us.
Yes, sir, thank you.
Good job, Carla.
We trained you well, Commissioner Pick. Next year, maybe
You didn't have any questions.
Yeah, that sounded like a member of the presentation team.
Yeah.
That's good. Anything else? for you?